Myself briefly, I entered the university 1996. I got a specialty the 26, and then I working the veteran hospital for 13 years. At that time, I had a lot of experience for treat my patients. After that, I went to the university. So, okay. Please add me for the Instagram. Yes. A few months ago, I start the Instagram, so I need a follower. So you can scan me. Yes.
We will share.
Yes. During semester, I teach my patient, my student. So these days, vacation, so there is no class. I was very happy. So, and this photo is my family, my wife, and my two sons and my one daughter. This guy is very scared because always I don't need studying. Always. So it's very difficult. Also, the hands-on course is very helpful for dentists. So I was served the general secretary for Korean Academy Aesthetic Dentistry. At that time, we perio team provide the hands-on course. So this photo was taken the 2 years ago. The past 2 years, I was working. I served the general secretary for Korean Academy of Aesthetic Dentistry. At that time, he is Dr. Kim. He was ex-president of KAED. So it was very happy time. So far, soft tissue augmentation was focused on root coverage around natural tooth, also increasing keratinized gingiva around implant. Conclusively, the past years, we only focused the facial effect. Thick gingiva, thin gingiva, what millimeter of keratinized gingiva. But now, the paradigm, we focus the vertical soft tissue augmentation, vocal tissue thickness. So, in my clinic, the root coverage procedure only the vocal area. But this day, many periodontists try to augment the vertical tissue. So this is very common case in my clinic. This is the modified envelope technique, the epithelial CT. So I don't enough time. It is so summarize. As you know well, the de-epithelialized CT is very useful for root coverage procedure. And then we make the recipient site in many ways by using the tunnel technique, the many kinds of curette, and then we insert connective tissue graft in this way. Both of bone graft and soft tissue graft, it is very important thing is stabilization. So I try to stabilize by suturing on both sides and this ear and this area. And then I finish the suturing on medial side, and then I finish the distal area in this way. And then the last one is the sling suture. The start point and this area, and then surround the lingual side of tooth, and then to go back the start point in this area. And then the CT graph is to make the stabilization with the three kinds of suture, and then I make this outcome. And then the 2 weeks and stitch out photo, we can see this result. And then 4 weeks, and then 3 months, you can see this result. So in past year, we only focused the buccal side in this way. So other patients, I can show this case. She came to my clinic. She was 18 years old. So she had the congenital missing, and so she and her father and mother want to make the tooth for aesthetic demands. But as you can see, midline is on harmony. So also the gingiva line is on harmony too. So she needs the orthodontic treatment and soft tissue management and implant placement and bone graft procedure. So multidisciplinary approach for her are needed. So first, the bone graft by the titanium mesh and the fixed by the bone tag. But as you can see, it's very not enough the soft tissue, so we need the soft tissue management. At that time, I choose the VIP CT prep from the palatal area, and then I make this result. So you can see this outcome. And then she entered the university. So she had to come to my clinic only the vacation. Yes. So, and then 6 months later, I tried to implant placement. Finally. So I focus on the buccal side for the increasing the thickness. So I make the incision like this, and then I make the flap elevation like this. And then I make the drilling. Also, she finally the treat of the orthodontic treatment too. Anyway, this is the final result. So the past year we only focused the facial aspect, but today my lecture summary is about the vertical soft tissue. The paradigm shift is soft tissue as biological guard. The biologic reality, the 29, the Likambisius, he is a prosthodontist from Lithuania. He made a document, vertical soft tissue thickness 2 mm, make the significant marginal bone prevention as because the body needs the 3 mm soft tissue. So beyond aesthetic, moving past the traditional focus on buccal keratinized gingiva, we must now vertical tissue thickness. The functional necessary, it is functional requirement to protect underlying hard tissue stability. So bone stand hard, but soft tissue is guard. So soft tissue is very important. To 2022, he came to my clinic. He lost his implant past 10 years. So go back 2010. Other dentists, other my colleagues pressed the implant 2010. I imagine the baseline bone level, this yellow line, and he pressed implant and then bone graft. How about this placement? I think that it is supracrestal level because 1 year later, bone resorption we can see. And 10 years later, how about think about that? I think the cause of failure cannot be only one factor. However, this case seemed that it was difficult to make 2 mm, 3 mm vertical soft tissue because the implant level is supra on the bone level. This guy is prosthodontist, Lithuania. He made 2 big documents because we know about this documentation. As you know well, this group is supracrestal implant placement and the thick gingiva. The other group is equilevel implant placement and thin gingiva. But marginal bone loss is thin gingiva group. So he emphasized vertical soft tissue height. So in his documentation, in discussion area, the past document, previous study only focused facial aspect, the thin, thick, KT band, narrow band, mucogingival junction. But at that previous study, not record baseline the vertical tissue height. So he concluded that regardless of implant type of clinician skill, initial tissue thickness 2 mm over. So, and then the 6 years later, he made the other document. Initial tissue thickness is decisive factor for biology width formation. So we need to implant placement and supracrestal gingiva height is a matter. Also, as you know well, the platform switching is very good, but there is no thick tissue there's no platform switching benefits. So we need the soft tissue thickness vertically. So final conclusion is the vertical soft tissue thickness play a major part in early bone loss. So this diagram shows the vertical tissue height. The past year we focused on this area, but now we consider about the supracrestal gingival height and this. So the bone is very important. Bone is hard, but now we need a focus on soft tissue area. So in my clinic, this day I need to the autogenous bone, autogenous CT graft, but as you know well, the morbidity is high. So in this day, the substitutes sometimes used. So I can control the depth control, and then I check the gingival height. It is 2 millimeter. It is not thick. Okay, so we can two-way to control the biologic width. First, the depth control. The second is the gingival height to increase by autogenous or substitutes. So this is the one of kind of substitute for the collagenate base instead of autogenous gingiva. And then 3 and 4 later, you can see increasing the vertical tissue height. This case reported by my resident, as you can see, the adding suture, and then after the 3 or 4 months later, you can see the vertical tissue height. As you can see, this way. And supracrestal gingival height, protect the bone. So stop saying the SIG is good. Start asking why is SIG necessary. So our body needs at least the 3 millimeter of soft tissue. If not, they will try to create it even by resolving bone. So we call the biologic width around the implant. So we need the implant depth control. Also, we consider the vertical tissue height. This article is the systematic review about this theme. Soft tissue thickness, the critical determinant of early marginal bone loss. So, paradigm shift from facial to vertical. So, the gum graft surgery and substitutes, we can use that, but it is the case by case. So, this article is about the RCT. One is the by Geisley, the fibroguide. Other is the autogenous. So, two group result is same, but the patient's satisfaction is the other result because the clinician prefer the autogenous graft, but patient is not same with clinician because the less morbidity. This is the one of case, the immediate implantation, extraction, the implant depth control. The 5 years ago, I couldn't consider about the thickness of gingiva, but now I try to manage this thickness. So the bone graft and membrane, this is the result, but now I try to other things such as video. So immediate implant, I try to immediate, so check the bone level and then remove the granular tissue and then implant placement and then the depth control, the torque length, and then this is the substitute, instead of autogenous gingiva. This material help to make the vertical soft thickness, such as. So this day I try to make if there is a 2 millimeter vertical soft tissue, I try to make the more vertical tissue height. It is other case, and then implant substitutes. I try tugging around the implant. As you can see, such as healing, and then I make this outcome. So we need consider about vertical soft tissue. And then, okay, so past year we focused on this facial aspect, but now we need the vertical soft aspect. Now we have to consider this area. And then, as you can see, I refer from the private clinic. We need the facial aspect is narrow band. So at this case, need the pre-gingival graft for increasing the KT band. But if it is good position of implant was placed, after that we need consider the vertical. And then it is other case. This is the initial case. So around the natural tooth is the facial aspect, also the past aspect. So due to this Professor Drew Kelly, he is in our field, he is the very, very good expert about the CT graft. When I saw this article, this is just a case report because it is very challenging case because the class 4 is the collapsed the bone and soft tissue, so we cannot treat in class 4 gingival recession. But when I saw this article, it is impossible for me. But he tried the CT wall technique, we call CT wall technique. CT is the many ability to make the bone, tissue, but as you know well, around the teeth is very difficult to make the bone. So he tried the good quality of connective tissue around the teeth is for aesthetic. So not bone. The past year always we make a bone, but now we change the outcome about the soft tissue. The good quality of soft tissue is the long-term stability. So these days we need to make the soft tissue, such as this case. So I had experience to participate in international symposium of soft tissue management. For 2 days, all lecture about the soft tissue, connective tissue, soft tissue, all lecture about the soft tissue. So this photo is very honored with Jukelli, but he introduced his case report, the 10 years result. So CT wall is very, very good choice, Crespo defect. So now in Korea, the Academy of Periodontology resident, they have chance to their own case presentation per 1 year. So this day the resident present his case by CT wall. So CT wall case is the common now. So the concept is like the collapse, the CT wall, the lead area is not bone. Good quality of connective tissue. So it is aesthetic demands. We can feel that. So this case is the one of case. X-ray show the cemental tear or root fracture. So I check this area. You can see the cemental tear. So this case is very difficult to the bone, make the bone, right? So I try make the soft tissue of good quality. So, but past year, the endogain or the regeneration material is very difficult to the maintain. But now, the tetracycline for the chemical treatment, and then artificial substitutes to protect the around the tooth. And also, we can suture such as this, and then I try to endogain, and then I try to collapse, prevent collapse. This is the preliminary result. This day in our field, we make the concept about the making the connective tissue graft. In past year, the bone, this day is soft tissue. It is my conclusion. So, the Stefan Picker is the famous the periodontist. His article that peri-implant marginal bone level implant soft tissue augmentation, but I like this word. Bone stand hard, the soft tissue is hard. So hard bone tissue augmentation is very important. So we always the surgery, during surgery, we grab the bone graft and the membrane. All focus. We try focus to make the bone, but for long-term stability, we need the soft tissue. So, hard tissue augmentation is the space. The soft tissue augmentation is the guardian. So, it is very important, soft tissue augmentation. But this is the part 1. Now, this is part 2. The absolute is very essential factor is the solid and stable connection between the fixture and abutment, because the loose connection is break the soft tissue and hard tissue. So it is essential. Without this mechanical integrity, biological stability cannot exist. So we have to choose the implant for quality control in this area. So paradigm shift from bone to the soft tissue, but the abutment fixture connection is essential. So I show the full case by the One Day Biotech S picture. As you know well, the Dr. about said to the remodeling, but in clinically, 6 months from the we need the 2 periapical radiograph. The first is at the time of the loading, start of loading, and then 6 later at the same direction is 2, because about 6 months the first remodeling is finished. So when we see the periapical radiograph between the initial and 6 months, at that time we see if we see the stable, so therefore if we see the stable level, the implant is the stable. But for first 6 months, we see the small resorption about 0.5 millimeter. The 1 year later is the 90% is 2 millimeter resorption over. So 6 months early remodeling is very, very important. So we always taken the 2 radiograph. First is the connection of the restoration, and then 6 months later. So I pressed the S picture, the 2 years, so it is short time result, but I show the stable marginal bone level. So this is the first case. I show the photo and video. The first case, she came to my clinic. Is hopeless, the first and second molar, so extraction, and 2 months for first healing. As you can see, that this second premolar is the questionable. So I told her, when we do the surgery, at that time we can decide for maintenance or extraction. She agreed. So preoperative compensity. How about, do you think, Dr. Muhammad, you save or extraction?
The premolar second?
Yes.
Because I don't like headache eye extracts.
Yes. Me too. So at the surgery, this tooth is questionable. The extraction, one drill kit, and S picture. I think that the macro design of S picture is round apex is good for sinus augmentation, and also reverse cut is very good initial stability, make it easier, I think. So it's very good. And then press implant the two of X picture, and then this premolar immediate implantation is very good stability, so I can connect the healing abutment. This area is good stability, but I need the bone graft, so I choose the cover screw. This is a healing abutment, it's cover screw, and then I suture. It is short video. The first time is the original speed, and then as you can see, the second premolar is the questionable. I make the incision such as this. The number 15 is the good for the wide area. Yeah. I feel the bone level and bone touch by this way, and then after that, number 12 blade is good for the adjacent area as this way. I cut the periodontium such as this, and then the circular area, okay, and then this way, okay, and P24 elevator is the good for the reflection such as this, and then now I told her your second premolar is very mobility, to mobility, so extraction, I follow, taken, and then now I small vertical incision to wide visualization, and then I use the Lindemann drill for the correction, the direction of implant placement, and then check the direction. The one drill kit is to include the stopper, so it is helpful to the beginner or the check the inferior alveolar nerve, and then implant placement, and then latchet for the depth control, such as this, and then okay, I try to check the lingual level, the subcrestal gingiva, subcrestal bone level 2 or 3 millimeter, and then drilling for the first molar area And then one drill kit make the such as the trap handle is a flexibility, so sometimes the autogenous core can be used, such as this. And then I make the remove the check, trimming, irregularity, and then place the implant for the parallel, and then 5 of 0 diameter placement, and then I check the around the defect. Although this defect is a contained defect, so it is favorable, but I think the protection from the epithelialized tissue, I think, so I cover the collagen membrane and then make the hole, and through the hole the healing abutment connection such as this, and then I finish the surgery. And then this is the panoramic radiograph, and the stitch out, and the 2 months and 4 months for the entry, for the connection, the healing abutment, and then I check the field area in the healing abutment connection, and then this is scan body for the impression, and then within the 4 months ISQ is 83 and 85. This is final result. As you can see, how about this design, the abutment? Sometimes why you open the gray color, but I am a periodontist. I think it is don't need cover the zirconia, because as you can see, adjacent tooth already exposed the root surface, so the posterior part is the maintenance easier. Yes, so I always check do you use the interdental brush? So it is very important, excess of cement of the cringing, always check taking the radiograph. This is the last May. She is how about this result? It is very important article for me, because I'm periodontist. So after finishing the surgery, I refer to the prosthodontist, such as you. They make the result, and then the patients came to me, but sometimes abutment emergence profile is so wide. So I need a reference, but this reference is very recently. The Yonsei University perio team is the retrospective result already 30 degree over is dangerous, but that is the retrospective study. So they make the 4 kind of abutment and press in the dog. So day 20, 40, 68. The final result is the 40 degree is the starting point of dangerous. So as you can see, day is the diagram. As you can see, the narrow angle is the biofilm is so far. We make the distance, but wide emergence angle is the no room, no space for cringing. So if it is possible, we make emergency angle not over 30 degree. So they trigger point is 40 degree. So sometimes not anterior area, the posterior area, we need to emergency angle not over 40 degree. So sometimes this narrow angle is very important. So you please keep this diagram for the maintenance. So I sometimes make the retrospective study with our resident. So today you have the radiograph, this angle, because the emergency angle you have to check, because emergency angle is too wide, it is start to resolve marginal bone. So I try to make the bone, make the soft tissue, make the proper implant placement, but the final result is prosthesis. Prosthetic is the angle is very important thing. So sometimes we need to the exposure of the abutment level because prevent wide angle. So 1.5 years, I can see the corticalization. So it means the connection is very stable. So the X picture is the, although it is a short-term result, but the stable connection I saw by the periapical radiograph. And also, as you can see, this area is bone graft material. So if it is not stable, the connection, maybe this area already resolved. But the 1.5 years is not long-term result, but as mentioned before, first remodeling is the first 6 months, so 1.5 years is enough to make the stable marginal bone level, I think. So this is another case. She is the 78 years. So as you can see, in this area, as you can see, this prosthesis is not attractive, but he want to maintain because no pain is no he don't need to change the prosthesis. So, but this area is a deep pocket, so I try to make maintenance easier. So I prep surgery at the time of the implant placement. The prep elevation, the remove the negative architecture, and such as this. So, and one drill kit I use, such as this. The bone core can be used. The picture design is good, and the stability is 30. So I connect the healing abutment and suturing. The final result, the panoramic radiograph, the first healing. As you can see, this embrasure is open, so he can use the interdental brush, and then scanning. Just 2 months, ISQ level is 73. So how about the soft tissue response? And then final result. But zirconia, in Korea, zirconia is cheaper because the CAD-CAM is development. And then the final result, you can see the narrow angle, right? And then it's the 2 and 3 months later, this is follow. The third case, case 3, this is the a little of the narrow, and then my resident is the injection too many before the surgery, yeah. And then as you can see, the apical lesion we can guess, also CT. How about this? In text, at Yeson tooth had apical lesion, apical abscess. It can be effect to the implant result. So I called the colleague, the department conservative. How do you think about that? He told me, I recommend the delay the implant placement, and then I can do the root canal treatment first. So the suture, and then he went to the department conservative, and then he treat the RCT, and then I can try the implant placement such as this. It's not complete healing, but he know a symptom, and in near future it may be extracted, but he want to maintain. So I check and then drill the one drill kit, and as you can see the membrane at this area, at this time it is very important at apex design. Schneider membrane is the round tip sometimes needed. So it is proper bone crest, bone level, and I know adding apex area, just implant. So implant placement finished, and this is the healing abutment in the cover screw and the graft material and suture and the radial graft. And then as you can see, over the 2 or 3 meter, the crest level, and then the 3 months healing is very, it is enough to the keratinized gingiva, so it is don't need the flap elevation. So I use the laser for the punch technique, so I can find the cover screw and remove the cover, and immediately impression for the frost and the scan body and the final result. And as you can see, this is the immediate post radiograph, and then 4 months healing is lining of the radiograph of the panorama radiograph. This is last case. It is about this area. She already extract another clinic, so it is delayed. So flap the elevation by the one drill kit, the S picture, 5-point diameter, and then it is useful for the depth control is the laser marking. So it is the, maybe I think about the 1 millimeter. Yes. So if you use the latchet for the depth control, you can 1 millimeter sub, 2 millimeter sub, 3 millimeter sub. You can check by laser marking, and this So I can always I try to check the vertical tissue height and the subcrestal about 5 mm total. The 5 mm is the acceptable for this. So totally subcrestal is 2 or 3 mm sub and soft tissue and 2 or 3 mm, totally 5 and 6 mm. So when I use the 5 mm cup healing, is the same level, is the good for the make the proper emergence angle. So this is the last video. I check the maybe this yes. Yes, I maybe the crystal sinus augmentation. The other company from the Dentium. So I use the many kind of kit. So each of kit make the have advantage or disadvantage. I think so. I always during the surgery, the priest give me the sinus augmentation kit. So my circulating hygienist came to the during my surgery. They deliver the kit. I don't care the kind of company because I have to master all of kind of kit. So sometimes Megagen, Dentium, Wondrill kit. I always so at that time made the Dentium. So it is dome shape. Curette is very helpful to detection of the main remained bone, as you can see. So check the remained bone. Maybe this case is the remained bone is 5 and 6 millimeter maybe. So I tried to the 8.5 millimeter. So it needs the 3 or 4 millimeter added. So as you can see, the checking the level. Yes, and then irrigation for the perforation. This type of curette is some reflection of the separate the basal bone and the Schneider membrane, and then it is helpful for the checking by the crystal approach. And then I keep the part. And then, as you can see, this day, most of sinus kit has a reversed cut. So just drilling is the bone is the inside of sinus. It is very good development, I think. And then the spread, such as this, a little bone graft. And then implant placement as picture. And then I check the laser marking for the depth control. It is make this such as this. I try to 2 or 3 millimeter subcrestally. And then I check the initial stability. Sorry for my head. And then it is good stability. This material is for the just augmentation, not critical exposure of surface of implant, and the suturing and the final result of radiograph. This shape, apical shape, is helpful to the sinus augmentation, I think. And then you can check. And then the stitch out, the healing, and check the around the implant. And 3.5 months, the ISQ check, the 78, is very good. And the second stage is surgery was done, and scan body for the make the delivery processes, and the final result such as this. This is the that time of the delivery of restoration. As you can see, the around the implant, especially apical area, and the final result is good. Yeah. So I like to finish my lecture with the take-home message. The implant of gingival thickness around implant, especially vertical soft tissue, are matter. And then to create soft tissue 2 millimeter or more, the first implant can be subcrestally. The second is soft tissue augmentation. The while autogenous gingival grafting is standard, but the indication for utilize the soft tissue is the creasing. And soft tissue over bone, soft tissue protect bone. So soft tissue is very important. Given all this, the stability of implant picture abutment connection is crucial. 컵. Thank you. Thank you.